Hello, I'm Dr. Kimberly Ford. On behalf of CMEO Outfitters, I'd like to welcome you and thank you for joining us for part two of a three-part CMEO Pharmacist Central educational series entitled Patients with Hepatitis B, Medical Comorbidities that can impact treatment and prompt the provider to switch. The CMEO Pharmacist Central series is supported by an educational grant from Gilead Sciences. As I mentioned, I'm Kimberly Ford. I'm a hepatologist, associate professor of medicine in the section of hepatology, Department of Medicine at Temple University Hospital at the Lewis Katz School of Medicine in Philadelphia, Pennsylvania. I'm very happy to welcome Dr. Christina Madison to the program. Dr. Madison is the founder and CEO of the Public Health Pharmacist. She's also an associate professor of pharmacy practice at Roseman University of Health Science College of Pharmacy in Las Vegas, Nevada. Welcome, Christina.
Thank you so much for having me. I'm very excited to be giving this presentation with you today, Dr. Ford.
Awesome. So let's begin with our learning objective, which is to partner with patients with hepatitis B virus and their healthcare professionals to support therapeutic decision-making in the presence of renal and bone comorbidities. To review the goals of treatment, they include to impact the natural history of hepatitis B virus, firstly by suppressing hepatitis B viral replication, reducing progression to cirrhosis, reducing other liver-related complications such as the development of hepatocellular carcinoma and need for liver transplantation, and of course, thereby impacting long-term survival. The schematic to the right outlines some of the laboratory markers which are used to determine treatment success, including an undetectable hepatitis B DNA, and of course, loss of hepatitis B E antigen, and the gold standard, which is really loss of surface antigen, which is labeled seroconversion. So pharmacists really play a pivotal role on the collaborative healthcare team in helping to achieve both these short and long-term treatment goals. So I think at this juncture, it would be wonderful to have Christina do a brief refresher on hepatitis B screening and vaccination schedules. We're going to start first by reviewing the U.S. Preventive Services Task Force, or USPSTF, recommendations.
As you mentioned before, obviously we want to make sure that the most appropriate individuals are being screened for hepatitis B virus. So currently the USPSTF recommends screening for hepatitis B viral infection in adolescents and adults at increased risk of infection. So this currently includes any persons born in countries or regions with a high prevalence of infection, which is defined as greater than or equal to 2%, such as Asia, Africa, Pacific Islands, and parts of South America. U.S.-born persons not vaccinated as infants whose parents were born in regions with very high prevalence, which is defined as greater than or equal to 8%, as well as those who are HIV positive, those who are currently engaging in injection drug use, individuals who are men who have sex with men, and household contacts of sexual partners of persons with hepatitis B viral infection. Additional at-risk populations that the USPSTF also recommends should be screened and are part of our CDC and ACP guidance include individuals requiring immunosuppressive therapy, anyone with end-stage renal disease, including those receiving hemodialysis, individuals with elevated AST and ALT, infants born to a hepatitis B surface antigen positive mother, donors of blood, plasma, organ or tissue or semen, and then those persons who are the source of blood or bodily fluids, inmates in correctional facilities, persons with hepatitis C viral infection, and last but not least, persons with multiple sex partners or histories of sexually transmitted infections.
So Dr. Madison, in addition to screening, hepatitis B vaccination should be a primary objective for individuals at risk. Who are at-risk individuals that pharmacists may want to open up a discussion about vaccination status?
So that's an excellent question, Dr. Ford. And as you can see, our ACIP recommendations include those adults who may be needed to get additional screening or more vaccinations for hepatitis B vaccine. So that includes those high-risk individuals that I just outlined previously. So those who may come in contact with a pharmacist and may need additional vaccination are those who have a sex partner who has hepatitis B surface antigen positive, those who have sexually active persons not in a long-term mutually monogamous relationship, persons seeking evaluation or treatment for a sexually transmitted infection, and again, that MSM population that we spoke about earlier, or our men who have sex with men. So that really encompasses those who have a sexual risk or risk of exposure because of behavior. And then those who have a history of current or recent injection drug use, we also want to make sure are up to date with their vaccination. And this also includes any household contacts, residents and staff of facilities for developmentally disabled persons, healthcare public safety personnel at risk for an exposure to blood or infectious contaminated bodily fluids, individuals who are receiving hemodialysis and pre-dialysis, including peritoneal dialysis and at-home dialysis patients. And then also, this is a big one because we see so many of our patients with diabetes. Any individual who has diabetes mellitus who is less than 60 or over the age of 60 at the discretion of the treating clinician. And so again, we are really trying to focus on individuals who have that risk and could greatly benefit from vaccination. So we also want to make sure that we encompass a few other individuals who may also benefit from vaccinations. And this also includes our ACIP recommendations for international travelers to countries with that high prevalence or intermediate prevalence of hepatitis B virus, which we mentioned earlier. So Asia, South America, and then persons with hepatitis C viral infection, those with chronic liver disease, including but not limited to cirrhosis, fatty liver disease, alcoholic liver disease, autoimmune hepatitis, as well as those who have AST or ALT that's greater than 2 times the upper limit of normal. We also have those individuals that are currently having a positive HIV status, individuals who are incarcerated, who may be engaging in, say, illegal tattooing or engaging in injection drug use, and then other persons seeking protection from hepatitis B viral infection, even without an acknowledged or specific risk. And I think that's super important to mention, that that self-identified risk is all we need from a patient. If they are stating that they want protection for hepatitis B viral infection, we need to be providing vaccination.
So, Dr. Madison, let's focus our vaccination discussion on adults. What are the available vaccines and their respective schedules?
Absolutely. So we are very lucky that we have multiple vaccine presentations to choose from. They include our Energix B, which is recommended for all ages, including infants. We have our Heplisav B, which is only recommended in adults 18 years and older, not recommended for use in pregnant women. We also have Recombavax HB, which is also indicated for all ages. We also have some combination products, which are very useful, that protect against both hepatitis A and B. So we've got the Twinrix bivalent inactivated hepatitis A and B vaccination, which can be utilized. It's also available at a accelerated schedule for individuals who may be engaging in international travel. So you can vaccinate them at 0 and 7 days, and then 21 to 30 days, and then a booster at 1 year. So let's go ahead and talk in a little bit more detail about this vaccine schedule. So let's go ahead and start with our single antigen hepatitis B vaccines, which include Heplisav B, Energix B, and Recombavax HB. So as you can see here, our first vaccine that's available for your 18 and up is our Heplisav B, and we can vaccinate you with 2 doses 4 weeks apart, which is a great benefit to this vaccination. We also have Energix B, which can be provided at 0, 1 month, and then at 6 months to complete the series. And then if you have someone who is currently receiving hemodialysis, it's this schedule here where we would add an additional dose at 2 months and then again at 6 months. So a total of 4 vaccinations for complete series. And then our Recambavax HB, again, very similar schedule as our Energix B, which is going to be 0 at 1 month, and then the final dose at 6 months. And then last but not least is our Twinrix, which we talked about earlier. So 0, 1 month, and 6 months. Or you can do that accelerated schedule, which would be 0, 7 days, and then 21 to 30 days with a booster dose at 1 year.
Great. Dr. Madison, let's switch gears just a bit to talk about hepatitis B treatment, and in particular, who and when to initiate treatment. While the American Association for the Study of Liver Diseases, the AASLD, has detailed guidelines for the management of chronic hepatitis B infection, management or treatment of hepatitis B does not have to be driven by specialists, especially when such expertise may not be readily available. So the guidance, or the simplified approach that's presented on this slide, comes out of work from the Hepatitis B Primary Care Work Group, which is a multidisciplinary panel of national experts. And they published this simplified guidance specifically for primary care providers. So this chart comes from the guidance document that was published in February of 2020. And I think that there are some key things to point out. So you need some key pieces of information about your patient. So the first is whether they have a history of cirrhosis. That could be established by biopsy if they've had that in the past, by abdominal imaging, or by other non-invasive assessments of hepatic fibrosis. So that's the first piece of information to know. The subsequent 2 pieces of information to know are the hepatitis B DNA as well as the ALT. So we're going to talk a little bit about what we now consider a normal ALT in the next slide. But I do want to point out the fact that the ALT range is probably going to be a little different from what providers are used to. We'll talk about that in a minute. The AASLD guidance also requires that there's an assessment of hepatitis B antigen as well as antibody. That is not required here in this simplified guidance. So if we take the first row of the chart here, so this applies to all patients with chronic hepatitis B infection who have a history of cirrhosis. They can have any hepatitis B DNA level and any ALT. So that means a normal ALT or an abnormal ALT. And the guidance here is to treat with antiviral medications. In addition, there's going to be monitoring of the hepatitis B DNA and the ALT every 6 months. And for routine cirrhosis care, such as the performance of an upper endoscopy for screening of varices, and for hepatocellular carcinoma surveillance, individuals should be following with either a gastroenterologist or hepatologist. Additionally, all patients with decompensated cirrhosis should really be following with a hepatologist, and a determination made as to whether liver transplantation evaluation is required. Going on to the next row of our chart here, this refers to the patient who is non-cirrhotic, who has a high hepatitis B DNA level, and they have an elevated ALT. Again, we'll talk about what an elevated ALT is. And the recommendation, again, is to institute therapy with antiviral medications. Here we can see this is the patient with elevated hepatitis B DNA and a normal ALT, and that patient will be monitored every 6 months with a hepatitis B DNA and the ALT, and a fibrosis assessment to be conducted every 2 to 3 years. In the last row of this guidance, we see here people with a low hepatitis B DNA. so less than or equal to 2,000 international units. If they have an elevated ALT, the thought is really that we should be ruling out other forms of liver injury. And if the ALT is normal, that we should be following patients serially. So I think that this is a great simplified approach. It really helps to break things down, and it really means that some of the treatment of chronic hepatitis B infection does not have to occur in the setting of having a specialist available.
So what are normal ALT values in healthy adults? So, Kim, the simplified approach to treatment as well as the AASLD guidelines refer to ALT levels as 2 times the upper limit of normal. Is there an easier way to remember what that really translates to?
Sure. On this slide, we see a great representation of this. And I want to give the viewers a little contextual background regarding how we now determine what is a normal ALT. So when I was training, we would actually look at the upper limit of normal range for the particular laboratory that determined the ALT value. And what we've come to appreciate is that normal reference population perhaps included patients that had underlying chronic liver diseases that weren't appreciated. And in fact, there are also linear relationships between ALT and body mass index and ALT and gender. So how we've come to appreciate what's a normal ALT now is a bit more refined. So we don't just use an underlying population of who we perceive to be healthy individuals. Now there's also a determination of whether there's perhaps underlying liver disease that's not appreciated in determining that healthy cohort. And so many studies have determined that a normal ALT for a woman is 19 and a normal ALT for a man is 30, which is certainly much lower than, when I was training. I think a good rule of thumb is that anything over 25 for women and anything over 35 for men is considered abnormal. The other thing that I want to point out is that patients with a normal ALT can certainly have significant underlying liver disease. We have seen this in our experience with hepatitis C infection, of course, chronic hepatitis B infection, and other chronic liver disease processes such as hemochromatosis. So you shouldn't be fooled into thinking that a normal ALT means that there's no underlying liver disease. Lastly, we also understand now that an elevated ALT is associated with adverse liver outcomes. So really determining what that normal ALT is and treating to that is pretty important.
So what are some of our treatment options for these types of patients, Dr. Ford?
So the key treatment options include the highly potent antiviral therapies that we see here displayed on this slide. So we have entecavir, we have tenofovir diisopropyl fumarate, which I will call TDF intermittently throughout the talk. And there is also tenofovir alafenamide, which we call TAF or TAF. Certainly, interferon is one of the medications that can be utilized to treat chronic hepatitis B infection. That tends to be in younger patients who want a finite duration of therapy. They're not interested in prolonged or lifelong therapy. And certainly, there are adverse events that can be associated with interferon use. So we're not going to talk about that specifically today, but certainly in clinical practice, these are the 3 agents that are utilized. Entecavir is started at a standard dose of 0.5 milligrams once daily. For those patients with decompensated liver disease, 1 milligram once daily is the recommended dose. And entecavir can be taken 2 hours before or after food. There are certain side effects associated with entecavir. These include fatigue, dizziness, nausea, headache, and are reported in over 3% of those patients on this medication. A dose adjustment is required if there is underlying renal dysfunction. And Also for patients in whom lactic acidosis could be a concern, that should be evaluated promptly. For the TDF preparation of tenofovir, it's 300 milligrams once daily by mouth. This can be taken without regard to food. Again, we see some GI side effects, nausea reported in 9% of patients. Post-marketing surveillance has identified some adverse events associated with therapy. They include nephropathy, Fanconi syndrome, osteomalacia, and of course, lactic acidosis, which I had mentioned with entecavir. There's also a dose adjustment here in the setting of renal dysfunction. And it's important to monitor for renal health and bone health while patients are on the TDF preparation of tenofovir. And then lastly, the TAF preparation is 25 milligrams by mouth once daily, and that's taken with food. Again, we see some of the same side effects emerging, so headache, lactic acidosis is also of concern here. This tends to be the preferred agent for those patients who already have some renal dysfunction at the time of initiation of therapy. We'll present a bit of data later on in the talk to suggest that if your patients have bone disease, osteopenia, osteoporosis, that perhaps they should be initiated on the TAF formulation of tenofovir as well, as there are improvements that are seen in bone health while patients are on that preparation. So this is a really nice summary slide that goes over the table, but differentiates those patients without cirrhosis versus those patients with compensated cirrhosis and decompensated cirrhosis. And I think the important take home from this table is that tenofovir and entecavir appear in the preferred column for each of these disease states. There's some other medications that are listed, including adefovir, lamivudine, talbivudine. These are alternative or non-preferred agents. So for most patients that you're going to see in the office who meet treatment guideline or treatment parameters, they would be initiated on one of these three medications. On the table, there's a mention of pegylated interferon. Again, this is for younger patients without cirrhosis who may want a finite period of treatment. So, Dr. Madison, as with any chronic disease, chronic hepatitis B doesn't exist in a vacuum. Let's shift gears to talk about comorbid conditions that may impact treatment decisions.
Absolutely. And just as a friendly reminder for those great charts that you had earlier, these slides are available for download for your reference, because that's some really amazing information that you just shared. So when we take a look at the impact of medical comorbidities in our patient population with chronic hepatitis B, current estimates suggest that only a third of chronic hepatitis B affected persons in the U.S. are aware of their diagnosis, and only a fraction are likely to have be in care and in treatment for early stages of their disease. And as a result of often delayed diagnosis and treatment, patients with chronic hepatitis B virus are presenting at an older age and are more likely to have liver and non-liver comorbidities that can further complicate their treatment course. So we take a look at this particular graphic. As we can see from the graph below, this is comprised of both commercial insurance and Medicare patients. And when we look at this, we see that we are overwhelmingly getting more chronic medical conditions as people are progressing through their disease state. It includes things like cardiovascular disease, diabetes, hyperlipidemia, hypertension, as well as renal impairment, which we know those with chronic liver disease often end up having some semblance of, hepatorenal failure.
Also, I thought that the study was interesting in that there was an increase in comorbidities over the age range of the patients who were included.
Absolutely, I completely agree.
So, Dr. Madison, how prevalent is osteoporosis in chronic hepatitis B?
Well, if we take a look at this particular graphic, we can see that over time, we're actually seeing a lot more patients, especially those who are not maybe getting as advanced care or maybe not going in for chronic checkups. For our Medicaid population, maybe they're not accessing the healthcare system as frequently. We are seeing that a lot of those patients are progressing to osteopenia and osteoporosis and potentially leading to a fracture. So that's what we're trying to avoid. And obviously, having chronic liver disease itself potentially could be a risk factor for poor bone health. But then when you put on top of that some of our treatment modalities, that may be also predisposing them to bone health issues. So we are seeing a rise in our osteopenic, osteoporotic, and fracture risk associated with chronic liver disease associated with hepatitis B viral infection. We are also seeing instances where individuals are having challenges with chronic kidney disease as well, which we did know is the case for those with chronic liver disease. And so, again, very similar to the previous graphic, maybe a little bit more on par with both our commercial and our Medicare patients combined, seeing that over time, we are seeing more chronic kidney disease. But for sure, for our Medicaid patient population, which may have other chronic medical conditions that may be contributing to this, we are seeing a rise in chronic kidney disease, which may mean that we will choose a different treatment that may be less impactful on both their bone and kidney health. So when we take a look at possibly switching from a drug that may cause more issues with bone and renal health to one that causes less issues with bone and renal health. And again, not to go into the weeds, but when we look at these drugs kind of on a pharmacokinetic basis, you see that tenofovir disoproxil fumarate, or TDF, there's more of the drug that gets into the periphery versus those target tissues, versus when we look at TAF, you have less drug needed to get into the correct space and to impact that viral load, and therefore you have less of an impact on some of those peripheral tissues, which include our bone and our renal health. So again, when we look at the switch data here, in particular looking at both hip and spine, you see that we do have a pretty marked improvement when we switch from the TDF to the TAF medication. And this was at week 96 when we're looking at the potential risk for hip and spine fracture.
For the audience, this data comes from a study that was presented in 2020 looking at patients with hepatitis B, chronic hepatitis B infection. Some patients came into the study and were switched from TDF to TAF. Other patients remained on TDF for the duration of 96 weeks. And as Dr. Madison was saying, there was an improvement in bone mineral density in those patients who actually switched from the TDF preparation to the TAF preparation. We also see an impact on renal parameters during the course of this study. So if you look at creatinine clearance, there was an improvement in creatinine clearance in those patients who switched from the TDF preparation to the TAF preparation of tenofovir, and in other parameters of kidney function. So this is beta-2 microglobulin. So this is great data now that we have here to suggest that TDF and TAF are non-inferior. So as far as viral outcomes were concerned, they were pretty comparable, but TAF really having a favorable impact on bone health and kidney health in the context of this study. So Dr. Madison, the pharmacist sees the patient much more frequently than the physician. Thinking about a patient on antiviral treatment, what are some counseling and teaching opportunities that pharmacists can take advantage of when seeing patients when they come in for their refills?
Absolutely. I completely agree with you. As during our current pandemic, we have realized the importance of the accessibility of a pharmacist, with, over 80% of all adults being within 5 miles of a pharmacy. So I completely agree with you. And so with that being said, there are some things that we can help with because of those frequent visits for refills. And then also, if the patient isn't coming on time for their refills, trying to decide, what can we do to help them with some of those adherence challenges. So the number one thing I would say that we can help with as pharmacists is the drug-drug interactions, especially when it relates to things that patients can get in the self-care aisle, right? So those OTC medications and supplements that they don't really consider to be medications can oftentimes interfere with our hepatitis B treatment modalities. And so some of the bigger culprits here will be things like milk thistle, some of the liver supplements, creatine supplements. Those are the things that, the patient thinks, innocently aren't going to cause any challenges, but really they don't understand that anything that you put in your mouth on a regular basis and into your body could potentially, cause interactions with your current treatment therapies. And so we also want to make sure that we're partnering with other healthcare teams to optimize our treatment of our patients. Because again, we don't do these things in a silo or in a vacuum, right? We're all doing this together, and it's that team-based interdisciplinary care that really helps to make sure that the patient is getting what they need and the most optimal patient care we can provide. So we also want to have that opportunity to discuss things like alcohol and substance use with our patients, which can be a difficult conversation, but we do want to make sure that we are having that open and honest discussion, because these are things that they may not be discussing in the doctor's office. Oftentimes, some of these medications require prior authorization, and so navigating that insurance challenges sometimes is definitely something that the pharmacist can play an important role in, as well as helping patients to understand what's on the medication label. So providing them with education about any food requirements that may be part of the directions that their medication has, and then any safety concerns that they may be thinking about or have questions about. Ultimately, we want to address any of the questions that may not have been able to be addressed during their primary care visit or their visit with their provider, because we know your time is limited, and we want to make sure that all of their questions are answered. As well as the issue with adherence, which I brought up earlier. So if they aren't coming back for that 30-day refill on time, really talking with them about what things are going on in their life that may be causing them to have challenges with taking their medication as directed. And then last but not least, recognizing that there are social determinants of health that may impact treatment and adherence, which include things like transportation, perceived, systemic biases or inherent, challenges because of their race, their gender, or their ethnicity. All of these things combined impact their ability to potentially get to the pharmacy and to get their medications on time.
This has been a great discussion, Dr. Madison. So before we head into questions, let's summarize our discussion with our SMART goals: specific, measurable, attainable, relevant, and timely. This is what we hope that our audience will take away from this presentation to apply to their clinical practice. The first of which is to partner with patients to help them better understand their hepatitis B infection, keep a watchful eye on patients' use of over-the-counter medications, supplements, and medications for comorbid disorders that might interact with their hepatitis B antiviral treatment. And lastly, communicate and collaborate with healthcare providers about patients' hepatitis B treatment plan to optimize outcomes. Dr. Madison, with that, I think it's time for us to let our audience join the conversation and ask some questions.
I can't wait.
Well, good evening. We already have a number of questions here in the chat box, so let's dive in. Um, so one of the questions that came up in the chat box is, as a chronic disease, do you have tips for encouraging patients to be more adherent to their regimen without being a nag? So first, I'm gonna ask Dr. Madison, her strategies. I'll tell you some of my strategies, although perhaps my patients feel like I'm a nag, but I think it's okay.
No, it's such a great question. And I'll say, one of the things that I really try to encourage my patients with is, what motivates them? Why do they want to be healthy? Why do they want to be in care? And that's what I use to sort of help massage the subject matter and not nag regarding why it's so important for them to make sure that they're taking their medications as directed. Also, that it's more than just taking your medications as directed. It really should be part of your routine, and that it should be a habit. Because if it's something that's forced, that's not part of your daily activities, or it's not something that you do that's on a regular basis, it's so easy for you to get off track and for you to undoubtedly miss a pill here or there. But if it's something that becomes incorporated to your daily routine, so something that you do regardless of whether or not you're sick or well, or if the sky is blue or not, or if it's raining outside, right? So if you are somebody who religiously eats your breakfast every morning, then you should make taking your medication part of that routine. If you are somebody that before you go to bed at night, you brush your teeth and you have a whole routine where you moisturize your face and do all of these things, something that is done on a regular basis, if you can incorporate your medications and taking your medications at that time, it really is more about a lifestyle and less about something that's a burden. And I think that's really the key to encouraging people to staying adherent to their therapies and understanding what their why is for staying healthy and well.
I completely agree. I think linking the taking of a certain medication to another part of your routine, maybe it's linking it to other medications, you take them all at the same time of the day, or you link it to brushing your teeth, having your coffee in the morning. I mean, whatever that sort of trigger is to remind you, to take your medications. And so whatever that tends to be for patients, I think is the best way to remind patients. And that's really what we're doing. We're reminding them to take
No
their
nagging.
medications on a regular basis. Exactly. No nagging, not at all. So another question that came up in the text or in the chat rather, is about screening household contacts. Which is actually something that I always recommend to my hepatitis B patients, again, without being intrusive. I try to suggest that household contacts go to see their own primary care physicians. I've also offered to see contacts in the family. We have access to vaccination in our clinic. And so it's a pretty quick way to make sure that family members actually have appropriate antibodies so that they're not becoming infected with hepatitis B infection. I don't know if you have other strategies, Dr. Madison, when you talk to patients with chronic hepatitis B and counseling that you provide around family members.
Absolutely. I think any encounter that you have with a patient or a family member is a potential missed opportunity to vaccinate. And so if we know that they're already at risk because they're a household member and they're a household contact, that's a great way to broach the conversation about vaccination. And if they haven't been vaccinated as an adult, this is definitely an indication to do so. Plus, the most current ACIP recommendations updated just this year, it actually is anyone who potentially could be at risk risk for hepatitis B. You actually don't have to have a compelling indication anymore for administration of hepatitis B as an adult. So I think household contacts would be fair game for that, as well as just, encouraging overall health and wellness of everyone in the household, including knowledge about, potential ways that they could become infected. Although we know that getting chronic hepatitis B, if exposed as an adult, is a lower risk, there still is a risk. And so, again, those household contacts would be at a higher risk than, say, just a general, potential contact, with an exposed bodily fluid. But again, going back to what are the risk factors, what types of behaviors these individuals are engaging in, especially if they're in, same-sex relationship, if they're MSM, all of these things go back to risk. And if the risk is high, then we should be offering vaccination and talking about harm reduction strategies.
I think that's a really good point. The other thing is that, I try to destigmatize
Absolutely.
the potential transmission through things like, sexual encounters or through drug use. It is important to note that certainly mucosal exposures, so sharing things like toothbrushes and razors and things like that, that's also a risk. So again, I think when you talk about the risks in total to household contacts, it's important to highlight those aspects as well. And sometimes that will be a very compelling reason for a person with chronic hepatitis B to be more open with family members, et cetera, about getting screened for hepatitis B and getting vaccinated if necessary. So let's go back here to the chat. So this is to Dr. Madison. Do we check hepatitis B antibodies for booster vaccine shots? If low, do we give a series of 3 shots? And I'm sure there's a lot of variability with respect to clinical practice, but maybe you could tell us a little bit about how you handle this.
Yeah, so this is something that actually comes up quite often with healthcare professionals because we are required to have hepatitis B vaccination for our clinicals and to work in hospitals, right? Because it's part of OSHA requirement and it's part of our risk for potential bloodborne pathogens. So this actually comes up quite often. And I'll tell you, there is still some debate within, sort of the public health sphere around this. Ultimately, there are some individuals that we call sort of non-responders to the vaccine. So they may have antibodies that just aren't reacting and they're not coming up on a blood test. So if you run a titer, they may not show those antibodies despite having received a full series of the vaccination. And so in those instances, if the person is high risk and is engaging in direct clinical care, there is the possibility that you can offer a revaccination with an additional series. But again, that's a little bit controversial because again, we do know that there are these sort of low or non-responders to the vaccine, but when they would be presented with the wild type infection, would actually be able to mount an immune response. So I think it would be on a case-by-case basis based on their overall risk of infection and ultimately the appropriate documentation of whether or not they did receive all 3 of those doses at the appropriate interval.
No, I completely agree with that assessment. I think because many of my patients have chronic liver disease, I tend to be quite aggressive about checking the hepatitis B surface antibody. And if they have had a vaccination series that's well documented, I'll do a booster. If I cannot find documentation for that, I'll actually repeat the entire series. And again, as Dr. Madison highlighted, if patients are at higher risk, I am more aggressive, certainly for healthcare professionals, particularly those who work in settings where they're around blood frequently. For instance, if an assignment is in the operating room, for instance, that's somebody I tend to be very aggressive about, trying to make sure they have appropriate antibodies. There is an amnestic response, meaning you can check the hepatitis B surface antibodies, and someone who's been previously vaccinated may not have appropriate antibodies. But if they were challenged, they would have an appropriate response. So I do agree completely with Dr. Madison's assessment. Um, so going back to a vaccine question, there was one question in the chat about whether these vaccines are covered by Medicare. And I'll ask Dr. Madison. It's not something that I know for sure. I assume that the answer to that is yes, but I would like to hear her thoughts.
Yeah, absolutely. So, depending on obviously your coverage within your individual plan, so managed Medicare versus Medicaid, right? Because this may be a Part D benefit, and this is part of that, routine vaccination for health and wellness. It should be covered. And then, if for some reason you have a plan that does not cover this and requires a prior authorization or a prescription, there are, instances where you can receive the vaccine through a program from the state, which is very similar to what we do for children. So there's a separate pot of money that is called 317. That's just the name of the funding source from the federal government. But that money and those dollars are specifically for uninsured, underinsured patients, or patients who maybe they have met their deductible, or something has happened and the coverage is not there. And so if there is a denial of that particular claim, those individuals can get the cost of the vaccination covered under that program as an adult. They would just have to cover the cost of the administration fee. But again, this is part of the ACA when we overhauled the healthcare system. Preventative medicine included vaccinations, which were supposed to be at no cost to all individuals.
And I will say that I have never had a patient come to me and tell me that a vaccination series, et cetera, had not been covered by their insurance. So I actually don't think that is a limitation to vaccination. So there is a question in the chat about particular side effects that pharmacists should be asking about. And are there specific questions that we would ask to provide more insight than the usual, how are you feeling? So I don't know if you have thoughts about that, Dr. Madison.
Yeah. I mean, I think it just depends on where they're at within their course of therapy, right? So we know that when they're initially starting up the medication, they can start feeling sicker, right? So they can have more adverse effects, sort of this issue with, sort of the startup syndrome that they could potentially get from starting up the medication, and when it starts actively, suppressing the viral load. So that is something that you will potentially see some systemic effects. They could have, flu-like symptoms, abdominal pain, discomfort, just like feeling overall just not well. But usually that subsides within the first month of taking the treatment. However, if you do have a patient who already has underlying renal insufficiency or has some kidney issues, you would want to be really careful with any other medications that they would be on that could be renally toxic. And I work with a population that tends to use a lot of supplements. And so I'm always asking about things like creatine, pre-workout, protein powders, anything that could potentially be an additional insult to the kidneys because you're already on a medication that can cause issues with kidney function. The other thing too is if they already have a history of things like osteopenia or osteoporosis, which we talked about during the presentation, that is also something that I would want to be very mindful and watchful of when they were on these therapies. So, explaining to them about, risk for falls, or, if they feel like their diet has changed, those kinds of things we want to know about. And obviously the supplements are a big thing. And then just routine monitoring of their overall labs will hopefully help to draw out any potential issues that they may have. And then I also wanted to mention things like OTC medications like ibuprofen could also potentially cause some renal harm. And we would want to counsel them on that as well.
No, I absolutely agree. I would say that for many of the patients I've treated in the recent past, I've had many complaints of gastrointestinal symptoms, particularly nausea when they initiate the medications. So that might be a good thing, certainly, to ask about. I think bone health and issues around bone health would be wonderful to ask about as well. And they certainly need routine monitoring. So I think checking in and just asking them if they have been staying in close contact with their healthcare provider and if they've been having regular laboratory draws so that their medications can be managed and any potential complications of the medications can be managed. So all very important. There's another question in the chat about whether, I would want those concerns relayed to me. And I've said this before. I feel like I say this every time we have a question and answer session, that I find the pharmacy staff to be really invaluable. I wouldn't be able to manage patients if I didn't get additional information from my pharmacist, the pharmacy students, the pharmacy residents, et cetera. And so I really view it as a healthcare team. We could not take care of patients without the entire team. I absolutely want to hear concerns. And honestly, I will tell you that I don't hear necessarily from the outside pharmacy, but I certainly hear from our internal pharmacy staff if patients are not on medications or they haven't had updated labs. So if I did not have that, I wouldn't be able to effectively manage my hepatitis B patients. So absolutely bring your concerns to the healthcare providers who are treating hepatitis B patients. It's very important. So looking back to the chat, there was one comment about some of the supplements containing NAC, which may improve liver health. So Dr. Madison, I don't know if you have comments about that. I am always concerned about co-formulation of some of the supplements with things that I'm not aware of. And we've seen clinical cases where people get into trouble with this and they have acute liver injury on that basis. So I am certainly hesitant to recommend or endorse use of things, even if they may include things like NAC that may be helpful from a liver perspective. I don't know if you have thoughts and whether there are resources that you utilize to look at some of these over-the-counter medications or supplements.
Yeah, so excellent question. I think that when we look at those supplements that are being utilized, it is a little bit challenging, especially if the patient is very gung-ho about doing things, more in the vein of like Eastern medicine, herbal products, teas, things like that. And actually, I see a lot of that with my AAPI community. Like they will prefer to take herbal remedies. And so I think that the key here is understanding that some of those products may have what we call proprietary blends, and therefore we won't know everything that's in them. And so when we look at it from, a risk-benefit scenario, in some of those cases, the risk may be outweighing any potential benefit. And so I do tend to discourage some of those things, especially if they're being actively treated for their hepatitis B status. If they are, sort of being maintained and they're, just watchful waiting, that might be okay to, maybe use things like some milk thistle here or there. But again, a lot of these supplements are unregulated. I do use the herbal dex. So Micromedics has a herbal dex. It's just a drug information resource. So I do look up some things there. I know Lexicomp has a few resources that you can try to cross-reference some of the herbal products, but not all of them are in there. And then also the fact that they're not regulated. They're not FDA approved. So it does make it a lot more challenging for you. So again, unless you can, really with all certainty say that what's in that product and what it says on the bottle is actually what that patient is taking, I would be very hesitant to tell them to continue taking those things, and maybe looking for some type of an alternative, maybe encouraging things like, decreasing their alcohol intake and maybe increasing, fruits and vegetables and a healthy diet, things that are not going to, be an insult to their to the liver, and kind of going that route versus, really asking them to take things that may or may not be beneficial for their overall liver health.
That's a great answer. There was just a comment in the chat, to elaborate on NAC. So NAC is N-acetylcysteine. It is an antioxidant. Perhaps affects fibrosis. I don't even know that we know all of the potential properties associated with NAC. It is the antidote that's used for acetaminophen overdose, but there is some data in acute liver failure patients that early use of N-acetylcysteine can be helpful in other types of acute liver failure, so non-acetaminophen. And so it does look like some of these supplements may be co-formulated with N-acetylcysteine, but it's not clear to me how much would be in these products. And so I don't suggest them either. I have a lot of patients who ask me about milk thistle, and I tell them, from the clinical studies that we do have, it doesn't seem to be all that helpful. But, it wasn't potentially harmful either. So I usually try to give them that information, and they can try and make their decision with that information. So going back to the chat, there was a question about how long people have to be on therapy. And I think it's a really excellent question because therapy can be lifelong. There are certainly a few clinical scenarios in which I would think about taking patients off of medications. And for those of you who have tuned in to the course on prior nights or prior days, certainly a patient who started in the third trimester of pregnancy to decrease mother to child transmission. That's someone who I would certainly take off of therapy in the postpartum period. If a patient has chronic hepatitis B and they seroconvert, so they lose their surface antigen and they develop surface antibody, that's also somebody that I would consider taking off of therapy. And there are a few other kind of softer endpoints, certainly that people can consider. But I do agree with the question that was posed in the chat, or the point that was made in the chat, that therapy tends to be prolonged and sometimes lifelong. And it's really important that you determine that a patient needs therapy before you start them on therapy. So for me, I take a lot of time with the initiation of therapy and making sure that therapy is actually what they need before just saying, here's the medication, please take the medication. I know particularly in young patients, it's going to commit them to decades of therapy. So I don't entertain that decision. I don't take on that decision lightly. I don't know if you have comments, Dr. Madison, about that.
Yeah, I mean the quick answer to that question is it depends, right? And really that thought process behind, if you're going to start somebody on therapy, then it's a big commitment, and so you just have to be really careful when you do initiate therapy, because it could be a lifelong treatment. And there's not a lot of instances other than the handful that you mentioned, that we would discontinue therapy because of the fact that this is a chronic infection that has no cure. It's really just, maintaining, the progression of disease, trying to stop them from progressing to hepatocellular carcinoma. That's the big thing here, is that we're trying to prevent any additional complications. And if treating them just for the sake of treating them isn't going to give you those same outcomes, then watchful waiting can be done. And a lot of times, if the patient isn't ready to be on treatment, it could also be detrimental and potentially cause resistance as well. So you have to take all of those factors into consideration before you initiate therapy, because again, it is a very big commitment, and the patient needs to understand that prior to initiation.
Absolutely. So we're just going to take one last question because we are coming up to the end of time this evening. The last question is, if a patient is controlled on their hepatitis B medication and has an abnormal ALT, what do you suspect? And for me, I suspect other forms of liver injury. I certainly suspect other viruses, and hepatitis D was asked about in the chat. So hepatitis B doesn't have the replicative machinery to make copies of itself. It depends on hepatitis B. So patients can be co-infected with both. When patients are initially diagnosed with hepatitis B, I will check the hepatitis D antibody to find out what their status is. And so if they have an abnormal ALT and previously they did not have a hepatitis D antibody, I'll check it at that point in time. If they have had a prior hepatitis D antibody, and the ALT continues to be high, it's just not a one-off number, then I'll also check for viral load for hepatitis D. And sometimes that has implications for treatment. So I think it's a really great question. Just because somebody is controlled on hepatitis B, it doesn't mean that they can't have a co-infection or they can't have something else going on. Drug-induced liver injury, we talked a lot about over-the-counter supplements and things. So I think that you always have to be vigilant. And if somebody is previously well controlled from the standpoint of their hepatitis B infection, kind of thinking out of the box and ruling out other forms of liver injury.
Yeah, I was just going to say the same thing. Obviously, I'm going to put my pharmacist hat on, right, and say that I think that the first place we should be looking is medications. If you see an isolated, elevation in their ALT, also, talking with them about alcohol consumption. There are occasions where our patients, despite the fact that we tell them to, refrain from it or to do it in moderation, they may have, gone on vacation and really enjoyed themselves, right? And so obviously those are things that we need to talk about with them. And then, of course, all the OTC products and all the potential herbal products out there as well. So
great. So unfortunately, that's the end of our time today. We've had many great questions, and unfortunately, we can't get to all of them this evening. But before we go, let me remind you of the key points or SMART goals for our program. They are to partner with patients to help them better understand their hepatitis B infection, keep a watchful eye on patients' use of over-the-counter medications, supplements, and medications for comorbid disorders that may interact with their hepatitis B antiviral treatment, communicate and collaborate with healthcare providers about patients' hepatitis B treatment plans to optimize outcomes. So thank you to our audience for all the great questions you sent in this evening. I hope you'll join Dr. Lauren Heinecke and me on July 13th at noon Eastern Time for part 3 of the series entitled Best Practices You Can Use, Ongoing Monitor in Patients with Hepatitis B. For additional clinician and patient resources, please visit CMEO Pharmacist Central at cmeoutfitters.com. Stay safe, and thank you again for participating and for providing the best care for our patients. Thank you.
bye-bye.